Good morning, everybody. I'm Rose Champagne, and I'm moderating today, and we are very excited to have Peter Stussy with us. He's one of our clinical pharmacy specialists, specifically in oncology at Advocate Aurora, and he is a wonderful resource for us palliative folks. And he's going to be talking about immunotherapy drugs and hyperprogression of disease. And so we'll have the presentation and then a little bit of discussion. Take it away, Peter.
Thanks, Rose. So as Rose stated, I'll be discussing this phenomenon that happens with certain immunotherapy drugs in oncology. These drugs have been around for about 7 years. They've been on the market, and this is a phenomenon that's been recognized in the literature, very debated. There are still some that believe that the drugs are not tied to this happening and that it's just the natural disease course for that patient. But the bulk of the literature very much says that this is a definite phenomena that happens. And that's why I wanted to bring it to you today, as you may have patients who are dealing with this particular situation. So I got nothing to disclose as far as anything I'll be discussing in today's presentation. A couple of objectives for you, just defining what immunotherapy drug hyperprogression is, looking at identifiers that might put a patient more at risk of having this happen, and then just trying to explain how this could impact a patient's prognosis and just how you would then, the bulk of the discussion I'm hoping to discuss, how would a palliative care provider then approach a patient who had this happen. So hoping that that'll be our bulk of the discussion today then. Feel free to type in the chat questions, those sorts of things as we go along as well. I'll try to address them as I can. All right, wanted to go over how these drugs are supposed to work. Obviously, with this hyperprogression phenomenon, the drugs are not working as they should. But how they should work is they work through receptor checkpoints. What the tumor cell does is it has certain antigens that T cells recognize. And the T cells recognize this as a cell that is not appropriate and not necessarily foreign, but has definitely gone off the railroad tracks here. So then it will kill it. What the tumor cell does in many cases, though, is it has the same receptors that other cells in the body use to tell the T cell, no, I'm okay. You don't need to kill me. These are checkpoint receptors. One of the main checkpoint receptors that is currently targeted in drug therapy is the programmed death 1 receptor. So that's PD1 listed here on the T cell. The ligand that the tumor cell shows is PD ligand, programmed death ligand 1, PDL1. And as you can see on the left side of this slide, that's the receptor connection where the T cell will recognize it as something it should not attack. But then on the right, these drugs block either the PDL1 ligand on the tumor cell or the receptor itself on the T cell. This then leads to the T cell recognizing the antigen as something that needs to be attacked and leads to tumor cell death. So we're ramping up the immune system to attack the tumors, basically, and you'll see large amounts of immune infiltrates in these tumors when they biopsy them while patients are on these drugs, if they are working as they should. So here are examples of drugs. I wanted to make sure you knew if you saw these drugs that your patient might be on. Probably the most commonly used are pembrolizumab and nivolumab, and then just behind that, atezolizumab and durvalumab. Those are all programmed death 1 and programmed death ligand 1 inhibitors. There is another checkpoint inhibitor that's out there right now, CTLA-4, ipilimumab. It's not used as often. It's sometimes used in combination with nivolumab. They're both from the same manufacturer. And there are other checkpoint inhibitors in the works. There was a recent article in New England Journal of Medicine with a new checkpoint called LAG3. So you'll see more and more of these. This is a huge area of industry study, and lots looking into ramping up the immune system to attack cancer. So what exactly is hyperprogression then? What's happening there? Well, what it is it's obviously just the tumor increasing in and expanding well beyond what we would normally see as normal progression in most of these tumors. It's a great acceleration in the growth of the tumor that you see in these patients. But there's no exact agreed upon definition. I have two definitions from a couple of articles that I reviewed here that seem to be the ones that are most agreed upon in the literature at this time, but I do want to be very clear, there is no exact definition. One of the things that both of these definitions share is that there's a time to treatment failure within 2 months. So it's a short time frame where you're giving these drugs and all of a sudden this phenomena happens. The first definition looks at just overall tumor burden and states that there's at least a 50% increase, and that the progression pace, so again, that acceleration, there's a greater than twofold increase then in that acceleration. While the other definition looks more on size, tumor size. So a greater than or equal to 10 millimeter increase in the measurable lesions, or they're looking at then overall tumor burden a little bit lower at greater than or equal to 40%, or a greater than 20% appearance in new lesions as well. So also sometimes you'll see brand new lesions popping up. So it's a little undefined at this point, but these are the various definitions that the literature is throwing out there at this time. If you looked at this on graphical form, you'll see the red line is hyperprogression. So basically you just have a straight up increase in the sum of the target lesion. So this is total tumor burden that we're looking at here. I also wanted to bring up the point that some of you might think, why are we using these drugs if we have a chance of hyperprogressing these tumor growth? Well, the other responses you'll see here is why we continue to use them, especially that durable complete response. There are patients that are, for lack of a better term, cured with these drugs. And these are patients with metastatic disease, sometimes everywhere. And they will have their disease basically just disappear. I'd say it happens most often in melanoma. And the median overall survival and the 5-year overall survival data on melanoma has shifted considerably due to these medications. So that's why they're continually being used. There is a population that sees a dramatic response in their cancer from these agents. So that has led to them being used at a very high pace, especially in metastatic solid tumors where there is a response. So I'm a pharmacist. I don't read CT scans, but I think there are some on this particular presentation who would see these, and I mean, even me as a pharmacist, never being trained or anything, can definitely tell there's a big difference in these. So these are a European patient. So the dates are day, month, year. So you'll see the 10th of August is the first one as an example. So the first scans on your left are, this is a submandibular carcinoma patient. So this is a head and neck cancer that has metastasized to the liver and the lungs. So you can see their treatment, the ones on the left are when they were on treatment with methotrexate. They then failed methotrexate and got the baseline one you'll see in the center. After moving from methotrexate, they moved on to an immunotherapy agent, nivolumab. And then you can see the first scan after starting nivolumab on the right. So this is what you might see on scans for hyperprogression. Obviously, you can see it is lit up considerably on all three slices with progression in multiple different areas. So I just wanted to give you an idea of what you might see on a typical scan with this particular phenomena happening. So how often does it happen? Well, we don't know, is the general response right now. It really varies based off all of the studies looking at this are all retrospective reviews. Nothing has looked at this prospectively yet. And depending on the cohort of patients, usually it's single center cohorts that are being published out there. So there aren't a lot of like multi-center larger cohorts being looked at, or they aren't defining and recognizing this particular hyperprogression prospectively in studies right now either. Most of the immunotherapy drug studies are still almost all industry sponsored for the most part, and obviously reporting this wouldn't look great for industry. So I think that's one of the reasons why it's not being reported and looked at very much. They just show it as another patient who failed treatment. So the cohorts that I saw in the studies that I looked at, anywhere from 4 to 29% of those cohorts had the definition that they decided as hyperprogression in those particular cohorts. Now, again, that definition varies a little bit, so you can't necessarily look at one cohort and look at the next and see much of a difference. But overall, looking at all the retrospective studies that are out there, it seemed to have a higher incidence in gastric, non-small cell lung cancer, and head and neck cancer. Again, these are very much smaller cohort retrospective studies. They really can't tie the phenomenon to specifically these cancers, but this is just what they're seeing upon their reviews at this time. So there really is nothing directly tying or showing us that, yes, this person's definitely at higher risk, this person's at lower risk. There really isn't that available. There's just upon review what they're seeing. So you might be asking, well, how does this happen? How could you have a drug that's supposed to be working in this way and helping the patient all of a sudden just accelerate the growth of the tumor? It just, you know, how does it happen? Well, the true answer is we don't really know. But there are some ideas that are out there. Could be due to certain genetic mutations in the tumor that leads to the drug not responding as it should and instead accelerating that tumor growth. Some of those mutations are listed here that have been hypothesized. Another one that has popped up in a couple of different literature sources are that these drugs might actually stimulate immune suppressors in these tumor microenvironments by impacting effector T regulator cells. And what it does is it knocks out the T cells. These effector T regulator cells will tell the immune system to back down in that tumor microenvironment, and then the tumor kind of explodes from there, for lack of a better term. But much like we don't really fully understand how these immunotherapy drugs work fully yet, we really have just ideas but no definitive answers on how they're causing this hyperprogression either. So what does this mean for the patient as far as prognosis and whatnot? Well, we don't know, again, for sure what it means, but based off of the retrospective reviews that have been done, they've looked at those patients who have had hyperprogression versus those that have not, and looked at prognosis then and overall survival for those patients. Obviously, if you have this phenomenon, it's very well reported that patients generally come in with an acute increase in symptoms, and that prompts the scan that then shows the hyperprogression. So depending on what the tumor is and where it's located, you could have all kinds of different symptoms based off of that. But looking at various retrospective cohorts again, there is there seems to definitely be a reduced overall survival in these particular patients, which makes sense. So you can see the numbers there. A couple of the retrospective reviews did show statistical significance. Others just showed a trend without statistical significance. But it's generally agreed upon that overall, this is bad for prognosis, just to summarize it. So now I wanted to move on to the discussion part of the topic today. First, I wanted to ask, has anyone seen this in a patient where, or thought that now looking back that that this phenomenon exists? Is this something that you've had a patient experience? Or also throwing out the question, if you now saw a patient who had this phenomena happen, how would you address it? You have a situation where a drug that likely the oncologist is telling them may help their cancer and help it, shrink, all of a sudden accelerates its growth.
I think it's interesting because, I think patients have can have a real connection to these drugs, right? They're like, oh my goodness, this is what's gonna help me, cure me. And I'm curious, when this does occur, what is that discussion? Because I know I don't deal in oncology, but I know with heart failure, when you are taking something away that originally you have said, this is potentially going to help you, patients are really reluctant because, they think that is what is helping them. So I'm curious if that has anyone experienced that?
Hi, this is Maureen with Palliative here at Luke's. I think also it comes down to how it was presented when they initially started it. I think, there is this risk of this happening. Again, this is on the oncologist side, not from palliative, but this risk of this happening. And then, I can see patients sort of clinging to this could potentially cure me, kind of hope, but then, and maybe forgetting about the potential for this to happen. But I actually have not seen it happen, but I think that if it was to happen, my best guess is the oncologist would stop it. And then we would talk about, how unfortunately this has happened now. You kind of knew this was a risk, and then we kind of just have to go from here. But I think, it does come down to how it was discussed at the outset, in my opinion.
Hi, this is Pooja from Aurora Palliative here. I feel if we are seeing these patients who have this hyperprogression, especially if you are seeing them in clinic or in the hospital, there would be worsening of the symptom when there is this much amount of hyperprogression. And, instead of waiting to repeat a scan in usually 10 weeks or 12 weeks, if you are seeing worsening of symptoms after starting immunotherapy, repeating a scan earlier, maybe after 3 weeks or 4 weeks, just to see if there is progression of disease. And that would give us more chance to stop this treatment, because the longer the patient is going to get exposed to these treatments, there is going to be significant hyperprogression. So if we see worsening of symptoms after starting this treatment, I think this should be in the back of our mind that there can be hyperprogression, and maybe advocating to get an earlier scan rather than waiting for it.
Hey, Peter, can I ask you to go back to the pseudo progression slide? Because that really makes me feel uncomfortable.
Yeah.
So here we are in the hospital, something is looking worse. And maybe if we wait this out a little bit, we're in pseudo progression and things are going to continue to get better. I mean, it's like we're dealing with COVID all over again. We're dealing with uncertainty and layers of gray, and we can tell people what we think that we know, but it's hard to know for certain.
This is Leanne. The interesting thing about that graph, of course, is that it's not real data, right?
No,
And
no,
so-
this is just a general
Right.
pictorial
Mm.
of the various responses you may see. And
I guess-
obviously, this isn't all of the possible responses either.
Yeah, my thought was if you go back to your imaging slide, one more, that it would be really hard to call new lesions pseudoprogression. That would be one way to be able to help distinguish, in this particular one, those new lesions are not pseudoprogression. The, pseudoprogression is tumor, right, local tumor effect because of treatment that makes cancer that you knew about look bigger or worse temporarily. And that clearly new lesions would not be pseudoprogression, or at least that's been my understanding. I think this is really a great talk. And I guess my big question is, I think this is what the oncologists are presenting. I think that definitely changes how we would react, because I agree wholly with what's been said by Maureen and Rose and Pooja, that if it was sold as a potential cure and the potential for this to happen was never even addressed, the patient's really going to struggle with the idea that this could be causing problems, versus if it was advertised that there are these potential worsening or listed as a side effect or potential thing that can happen. I think that does make the discussion slightly easier. Again, I think it still is really hard, especially when some patients are getting such great durable responses from these meds.
And I will make a couple of points about pseudoprogression. What often happens with pseudoprogression is you possibly could see new lesions, but you'll see shrinking in other lesions. So you'll see a mixed response oftentimes, but the total tumor burden will increase. What has been described is that you'll see at least a response in some lesions, while in hyperprogression you really would not see a response in any lesion at all. All of them would be generally progressing, and that's why they've really tried to define some of the tumor burden and the time to progression and et cetera in the definition of what hyperprogression is, because as pointed out, this could be somebody who could possibly respond at some point, but there's a definite difference between what that pseudoprogression would look like on a scan and what the hyperprogression would, is what they're trying to define out there right now. Again, this is still relatively new and not defined well in the literature.
There's some good questions here. Thomas said basically that maybe not viewed as hyper effect, but we could be mistaking this as progression of disease, which I think is a really good point. And then this is a question I had. If you then stop the therapy, does this phenomena stop? Or what's oncology's next step, I guess, in a situation like this is another.
Based off of the retrospective reviews of this phenomena happening in specific patients, they did see a decrease in the acceleration of growth when the drugs were stopped. One of the issues with stopping these drugs is they don't leave the body soon. They are broken down over weeks within a patient. So it's not an immediate, like all of a sudden it'll back off, unfortunately. I do see some questions about the oncologist community and what they're saying. This is not a broadly discussed topic at this time, I don't believe. I haven't seen a lot of this in the literature or coming up at our ASCO abstracts or other places at this time. Off the record, I did discuss with a couple of oncologists here at my health system, and they did not stress this particular phenomenon to patients when they discussed these drugs. They, tend to focus more on the positive possibilities from the medications versus this phenomena. And because they can very clearly show in the studies that are done, well, 45% of patients responded to this drug, 55 didn't. That's the sort of data that they may bring up. They'll say, response or no response. They won't necessarily talk about the type of response to patients. And that's what they've traditionally done with chemotherapy treatments as well. So it's how they were trained and how they're used to it. This is kind of a brand new area that's showing them new things, and they didn't seem to be necessarily adjusting the conversations and how they had them based off of the new medications.
I appreciate that you brought up industry, because that, I think, especially with oncology, is because things are happening so fast, and they're so heavily, linked. I think it is. And do you think that influences how the oncologists approach this?
I'm not sure, is my honest opinion. Based off of our organization's relationship with industry, there isn't a lot of direct back and forth between our providers and industry at our organization. I'm sure there's more at other places. I do know we are not an NCCN institution, but I do know that obviously, since insurance coverage oftentimes based on what is in those guidelines and not, there is definitely a little bit more industrial push and money going to studies at those centers that are in the National Comprehensive Cancer Network. I think it would be inappropriate and just wrong to say that there aren't sometimes some conflicts there, but the extent of them, I'm not sure. I don't think this is necessarily trying to be hidden by industry. I don't see anything that reflects that is happening. I just don't think there's a lot of information out there on this phenomenon yet, and so it hasn't really been brought forward much, because again, these are small cohort retrospective studies. We don't have large cohorts of multiple centers looking over a greater period of time, seeing how many patients have this. It's hard sometimes to dictate if this happened or not, because again, as Dr. Bott had pointed out, you need to have a scan within 2 months. And it's standard not to have a scan until 3 or 4. That's kind of the industry standard in metastatic disease. So in order to truly state that this occurred, you would have to do that extra scan earlier on due to usually symptoms. So it would have to be a study that was willing to do scans more often than the current industry standard to see like what the true incidence and how often this is happening.
Leanne brings up a great point that with chemo, it's not a drug that is going to worsen the cancer. And so this is new territory to have something that could potentially do that. I mean, who knows? 7 years being around is not a long time. So perhaps at some point, if these drugs continue to be used, maybe the industry standard will change as far as scans.
Yeah, they are the top group of drugs used now. So I am sure all of you have seen these as treatments for patients you've seen for cancer. It has exploded. So, and as I mentioned, we still truly don't know fully even how they work to shrink the tumors and to bring in the immune cells.
This is Katrina over at St. Luke's. I think Leanne's point just makes me think, it's just such a good point in, it seems like oftentimes we see, the oncologists don't want to kind of quote, give up, where, if things don't respond, they oftentimes there's something else they can give, even knowing it, it may not help. So to have to kind of frame their conversation in with these new drugs that I might actually be giving you something that could potentially worsen your cancer. I can't imagine how hard that would have to be for them to say. Just knowing, kind of when you're working, you're really trying to improve things and give something that is going to give you more time and make you better. To kind of have to face that and put that forward at the onset, I would think would have to be really hard for them.
Well, and I think to that Leanne's point as well, we do know that chemo causes side effects, but that's wrapping your brain around a side effect versus worsening disease. I think, Katrina, you're absolutely right, is a hard one to explain.
And there's definitely a difference between these drugs not helping and accelerating, for sure, as well.
Yeah, so it sounds like everyone's thinking this is going to be part of new discussions for sure, which is great. And hopefully oncology is starting the discussions and we're not.
Yeah, I would agree that, kind of early on with this particular literature at this time, and as it becomes more mature and we learn more, hopefully the conversations will change as well then.
I could just add one more thing that, Rose, what you just said really struck me. I don't think we should ever actually be the ones to initiate this discussion with the patient. I think that would undermine their relationship with their oncologist really dramatically if we were to say, oh, this is probably because of your, this is hyperprogression, it's because of your immunologics. I think we have to be really cautious about that. I think it's worth having those discussions with the oncologists, but, just like we wouldn't tell, or at least we shouldn't tell patients if we think another physician has, committed errors or things like that directly, we should be really cautious about undermining that trust.
Absolutely. All right. Thanks, everybody. And thank you, Peter.
Thanks.
Have a great day.